Valve disorders. What are the purposes of the four valves of the heart? We are on page 766. Chapter 24. What are the purposes of the heart valves? What do they do? We have four valves. Two between each atria and ventricles, and then one in the pulmonic, one in the aortic. What's the purpose of these valves? Okay, they ensure that blood only flows in one direction. Blood should only move forward. They should not go back. Are we clear? Okay, so think of them as one-way swing doors, right? They only open one way and then shut, right? Open, shut, open, shut. So do they open and shut on their own, or do they respond to the pressures in the heart? Okay, they open and close in response to the pressures, okay? So when the atria contract, they open the tricuspid and mitral valves, blood moves from the atria into the ventricles. And then when it's the ventricles' turn, when the ventricles contract, the pressure changes. So now the valve shut, preventing blood from returning to the atria. Okay, so they serve one purpose. They open and close. What will happen if they do not completely open or if they do not completely close? What will happen? Is there still one direction movement of blood? No more. In such a case, if there is disruption, so think of it as the tunnels. So we have the, let's use the Midtown, the closest tunnel here. So if the Midtown tunnel does not completely open, let's say there's only one lane, or let's say some cars are backing up. Instead of going forward, some cars are going backwards. What will happen to traffic? There will be congestion, right? So same exact result in the heart. So the valves open and close to ensure a unidirectional flow of blood. If they fail to do that, then we have a problem. All right, so now it will lead to congestion. And what will always be the result if the congestion goes on for months, for years? What will the patient develop? Yes, Ms. Copeland? Oh, so what are all those signs and symptoms of? What condition? Heart failure, correct? Okay, so therefore the end result of valvular disorders are what again? Heart failure. Other complications can also arise. So you have more acute complications because remember, heart failure is a chronic condition, yeah? So that will result over time. However, you will have short-term complications, more acute complications as a result of valve disorders. Most life-threatening complication of that is clotting, because what will happen if blood is congested? If there's blood congestion, that means do they move or are they staying in one place, in one chamber? What will always happen if blood pools in one section of your body instead of moving forward? Clotting will result. And that will be the more acute concern because that clot can cause a pulmonary embolus, that can cause a heart attack, or that can cause a stroke, right? Okay. There are only two problems in valve disorders. It's either a valve does not completely open, we call that stenosis, or a valve does not completely close. That's called regurgitation. Now, there's also a similar problem which results in the same regurgitation known as prolapse. So when a valve prolapses, that means it's like, think of it as an umbrella, a really cheap umbrella during a rainstorm. What happens to your cheap umbrella, the one that you bought for $2? What will happen if you have a storm? So it will fold backwards, right? So therefore, instead of protecting you from the rain, it will now make you soaked. Okay, all right. So think of it of prolapse that way. So instead of the valve opening and closing this way, so they will now fold backwards. Okay. So whether it's stenosis, regurgitation, or prolapse, whether the valve does not completely open or the valve doesn't completely close, what will happen? Is there a unidirectional flow of blood? No, it is disrupted. Will there be congestion? Will it cause heart failure over time? Will it cause clotting over time? Yes. So first question on your blueprint for exam 3 are the following: manifestations of each heart valve problem, or the common causes. Okay, so what will lead to these valve disorders? Okay, so in each page, that's all you look for. You look at the manifestations and the possible causes. Okay, what are risk factors for these valve disorders? Who gets them? Who are likely to suffer from these valve disorders? So if you go from page to page, here's the manifestations. Good thing though is it's easy to remember the manifestations. If you just look at the location, if you're familiar with your anatomy and physiology, that means it's easy for you to see what type of heart failure will result. So let's take a look at mitral valve, for instance. Where is the mitral valve located? Exactly. Between, is it on the right side or the left side? The mitral valve. So if you don't know where it is, we have a problem remembering manifestations. It's on the left side. It's between the left atrium and the left ventricle. So therefore, what type of heart failure will result whether you have mitral stenosis or mitral valve regurgitation? Left side heart failure. What about aortic stenosis? Where is the aorta? Right side or left side? Aorta. It comes out of the left ventricle. So where is it? So on the left side. So what type of heart failure will result from aortic valve stenosis? Left side heart failure. You get the idea now? Okay. So again, if you don't know your anatomy, you're in big trouble. All right? So I'm not repeating anatomy and physiology. You completed A&P 1 and A&P 2. Okay, management is, of course, there are two types of treatment here. One set are symptomatic treatment, meaning we cannot, let's say the valve cannot be repaired or cannot be replaced. That could mean the patient's age, for instance, or other comorbidities means they cannot survive surgery. Okay, so that would be one condition, which means we will have to treat the patient's valve disorder symptomatically, which means we treat what? What's the end result of any heart valve problem? Heart failure. So what's the treatment? Signs and symptoms of heart failure. Okay, so that's one option. But if it can be repaired or replaced, then that would be the better option. Because if you replace or repair the valve, will the patient still have heart failure? No more, because you eliminated the cause of the heart failure. Do we understand each other? All right. So now the surgery, of course, will be on a different section of the chapter. As far as heart failure, so you still remember management of heart failure? Did it include diet? Did it include medications? How many medications did we learn were used to treat heart failure? A lot, right? So we had diuretics, we have ACE inhibitors, we had calcium channel blockers, we had ARBs, okay, we had nitrates, all right? Okay. So nursing management, of course, is managing patients with what problem? Heart failure. Okay. And then, of course, watching them for the acute complications of clotting. So I won't bore you with each page. So look at again, just remember, where is the valve located? And again, whether it's regurgitation or stenosis, the same problem will result, which is heart failure. And what's the acute problem again? Clotting. Okay. So therefore, since we know these patients have a high risk for clotting, what will be part of the treatment? Anticoagulants. Okay. Okay, we'll learn that again when we get to that section of this chapter. So I already mentioned valvuloplasty, which is repair. Plasty is repair. And valvulo is, of course, referring to the valve. Or we can replace it. Now, as far as replacement, we have two options. The surgeon may replace it with a mechanical valve made of steel or titanium, most likely titanium, or replace it with another tissue valve. This is what we call also biologic valves. These are valves from cadavers, a dead person, or from animals. Now we have, when we say animals, we don't just go to the supermarket and then buy any cow or pig's heart, okay, and then get the valve. Now, when we say tissue valves, these biologic valves come from animals, correct? But these are specially bred animals. Okay, these are not the same animals you see on the farm. Okay, these are genetically specially bred pigs and cows specifically for this purpose, to harvest heart valves. Are we clear? Okay, so don't go to a farm or supermarket. Hey, my dad needs a heart valve, please. Okay, it doesn't work like that. Are we clear? You understand? All right. Like I said, I won't go with into that detail for each one. So you're responsible for managing finding out the manifestations. Get to make it easy to remember the manifestations. Remember A and P, where is this valve located, and what type of heart failure will result, whether it's left side or right side heart failure. Okay, let's discuss this section briefly. Again, it'll contain the same information I already mentioned. So nursing management, regardless of the type of heart valve, what is again the patient's problem? Heart failure. So here, look for signs and symptoms of heart failure, and then educate and treat the patient. There will be arrhythmias, and then arrhythmias, specifically the most common arrhythmias that result from these are either PVCs, or premature ventricular contractions, or the more serious ones will be atrial fibrillation or atrial flutter. We'll discuss those when we return next week. No, week after, because we have the 4th of July holiday next week. So it'll be July 11th, okay? Which is your ATI day. So we'll have class first and then ATI on the next half. And then what are these manifestations again? When we say it's dizziness, syncope, what are these manifestations of? Is there cardiac output? No. So therefore, if there's no cardiac output, is that acute or chronic heart failure? Acute heart failure. Okay, so there's no blood getting to your brain. That's why you faint. Okay, you have syncope, you have dizziness, increased weakness, you have chest pain as well, because your heart muscles aren't getting oxygen needed. That's what we call angina. We'll manage angina next semester on module 1. Any question on nursing management? All right, let's go now to the surgical management. So again, there are two options here. The doctors can try repairing the valve. However, if it's beyond repair, then it'll have to be replaced. Replacement again, what are the two options? Mechanical or tissue or biologic valves. Now, how is it repaired? Now, long ago, I'd say 20 years ago, the only option was to perform open heart surgery, meaning we have to crack your sternum open and then work on the heart itself. Okay, so it's a major surgery. We have to crack your heart, not only your sternum, but we have to cut your heart open and then get to the valve. Now, in the last 20 years, since the discovery of TAVR, TAVR, that procedure stands for transaortic valvular repair or replacement. What does that mean? They go through your radial artery or your femoral artery all the way to your heart to repair or replace a valve. Isn't that wonderful? So your downtime is very short. You go home in 1 to 2 days rather than spending 1 week or more and recovering for months or years because they crack your chest open, right? So therefore, people long ago, 80-year-old people who are deemed poor candidates for open heart surgery were just told, we can't do anything for you. But now, again, because we can do TAVR now, even 80-year-olds or older are candidates for valve replacements now. Okay, so the more reason people live longer now, and that, of course, it's not such a bad thing, but consider that will increase the cost of healthcare even more because now people live longer, right? So they will drain Medicare, Medicaid funds, which again, I have no complaints about. Now, since we don't have a role in the surgery, our role is simply to prepare the patients for surgery and then receive them after surgery. So we'll focus on pre-op, there's nothing special, right? Because again, we go through the radial artery now. Now, in the case of if they say the surgery has to be done through the femoral artery, then that means your role would be to clip the hair around the groin. Okay, what did I say? What do we do to the hair? Clip. Okay, there's no shaving involved. Okay, we do not shave the patient's pubic hair like a baby, right? Nothing like that. Okay, it's actually bad when you shave because you create microscopic nicks, and that's a contraindication. That's high risk for infection. Okay, what do we do again with the hair? We clip it. Okay, do not shave them clean. Are we clear? All right. Yeah, they just make half an inch incision and then insert the catheter and thread it up. What GI? Is your vascular system connected to your...
So it's through the vascular system. Yeah.
Where does your femoral artery go? Yeah, so your femoral artery runs through your stomach and your small intestine? No. Again, review your anatomy, okay, and then you'll understand. Okay, so I have no questions on the procedure itself. Again, our role is what again? Pre-op and post-op. Okay. Now, to make it short, post-op care, if it's the radial artery, nothing for us to do except monitor the radial artery. Usually it's a small artery, so therefore bleeding is not likely. And there are no activity restrictions right after the patients come back from radial artery TAVR or any procedure through the radial artery. They go home. They're ambulatory. We monitor them for maybe 24 hours for complications, and then the patient goes home. That's it. Femoral access will be a bigger problem because it's a much larger artery, so much higher risk for bleeding. So the patient may be on bed rest for 1 to 2 hours, and then we monitor the site for bleeding. Okay, so bleeding is our #1 concern if it's a femoral access. right? Okay, so what do we do when we discharge the patient? So I'll get to that section. So whether the valve was replaced or repaired, is the patient at risk for infection? Yes, that increases their risk for infection. All right, let's go to the nursing care after valve replacement. So I mentioned TAVR, so here's TAVR, right? So it's a revolutionary discovery, okay? A technique which has saved a lot of lives and made this procedure available to almost everybody, virtually everyone. Now, what would make the doctor decide whether to use a biologic versus a mechanical valve? For one thing, it's the age of the patient. Okay, which one will last longer? Something mechanical or something biologic? Which will last longer? Titanium versus a body tissue? Of course, titanium. So we're talking mechanical, correct? Because years after you die, what will happen to your body when you're under the 6 feet under? You'll turn to dust, right? What will happen to that titanium that was embedded in your heart? Will it turn to dust? It will remain as titanium. All right. So you get my point, yeah? Okay. So they consider the age of the patient. If the patient is expected to live more than 10 or 20 years, what do you think is the better option? Biologic or titanium? We'll go with mechanical, right? So if the patient's older, is it really necessary that we use titanium? Patient's 80, 78, 85 years old. Are they expected to live another 30, 40 years? Okay, let me discuss the implications after surgery, okay? Depending on whether it's mechanical or biologic valve. Okay, if it's a biologic valve, is it living tissue or artificial? It's living tissue, okay. So is it likely to attract blood clots or not? If it's living tissue. It's living tissue. It's like your own tissue. Will it likely attract blood clots? No, because it's not a foreign object. It's living tissue. However, if you put titanium in any part of your body, is it part of your body or is it foreign? It's foreign. Anything foreign will attract what? Blood clots. It will attract platelets. So what is likely going to be included in the care and therapy of a patient who receives a mechanical valve, whether it was repair or replacement? Anticoagulation will be required. And there's only one drug that is approved. If you received a mechanical valve, it's only warfarin. No other anticoagulant will work. Why? The drug company said so. Okay, there's really no rhyme or reason. So they conduct clinical trials, yeah, with any drug before it goes to market. Okay, so during their clinical trials, they discovered that among these people who were on mechanical valves and were put on anticoagulants, so one group had this type of anticoagulant, another group this type of anticoagulant. Well, the only group that did not form blood clots were the group who had warfarin, right? So therefore, what's their conclusion? What's the only drug, anticoagulant, that will work for mechanical valves? Only warfarin. That's the answer. Okay, so don't go asking a doctor or any nurse or anybody, how come it's only warfarin? Your answer will be the same. The drug company said so. All right. What about a biologic valve? Are they likely to require anticoagulation? Because the anticoagulation here is for life. No, there's no requirement for lifetime anticoagulation for people who receives a biologic valve. Are we clear on this? Okay. So I already mentioned the common complications of any vascular surgery. This is not only for valve replacement, okay? So anytime you access a large vessel, especially an artery, these are your complications: bleeding, clotting, infection, heart failure, hypertension, arrhythmias, hemolysis, or obstruction of the valve, okay? Again, this is not exclusively to heart valve repair or heart valve replacement. Anytime you mess with a major artery. Okay, so does this include cardiac catheterization? Yes, this is cardiac catheterization. All right. So here are pictures of heart valves. Again, questions won't be on these, but rather your nursing care. So what will we focus on? Intra or pre-op and post-op? Pre-op and post-op. Okay, so I already mentioned mechanical valves. So besides anticoagulation, which predisposes the patient at risk for bleeding, there also increased risk for endocarditis. We'll talk about endocarditis on the next topic. Tissue valves, again, are called biologic valves, and they require no anticoagulation. Okay, so here. So one of the indications for biologic valves are for women of childbearing age to avoid complications of long-term anticoagulation. Because again, who will require lifelong anticoagulation? Mechanical valves. Horses can also be used for biologic valve replacements. Okay, so cows, pigs, and horses. Again, are these just any horse on the farm that can go to Long Island, get a horse valve? No, these are raised by pharmaceutical companies, right? So these are expensive animals, right? And of course, there are always human cadavers. But which one do you think will last longer? The heart valve from a horse or heart valve from a human? Which one's stronger? A horse or Helder? I'll go with a horse. Okay, I already mentioned about anticoagulation, and then monitoring them for endocarditis. That's about it. Let's go now to endocarditis. So we've looked at the valvular diseases. Let's now look at the other conditions that can lead to valvular disorders. So one of them are infections of the heart. Now there are three layers of the heart muscle. So we have the endocarditis, which is the innermost layer. This is where blood touches. The second layer is the muscle layer, called the myocardium. So again, the innermost is called the endocardium. The muscle itself is called the myocardium. And then what do we call the sac surrounding the heart? The pericardium. Okay. Think of it as the scrotum of the heart. Okay, so if there's a scrotum for your testicles, there's a pericardium for your heart. And there's a little bit of fluid there in that sac inside the pericardium so that there's no friction as the heart go. Does the heart ever stop beating? How long has your heart been beating? So whatever your age is, plus 37 weeks, okay? Because your heart started beating 2 weeks from conception. Okay, so the heart started beating even when you were 2 weeks old inside your mama's womb, right? And then it's still, right. All right, so let's go now to the infections. Again, we have three types of infection here. We have endocardium or endocarditis. myocarditis and pericarditis. So we'll only focus on endo and pericarditis. Myocarditis is actually the same effects as somebody who has a heart attack. So we'll discuss the concept of myocarditis together with myocardial infarction next semester, right? Because it's the same effect. It's the muscle itself that is affected. Let's start with endocarditis. Now, there are two types of endocarditis. It's either rheumatic or infective or infectious endocarditis. When we say rheumatic endocarditis, yes, this is also infectious. However, it's not really contagious. All right, so this one is caused by rheumatic fever. Now, how do we get rheumatic fever? It's the same group A beta hemolytic Streptococcus. So same organism, same bacteria that causes strep throat can cause rheumatic fever and therefore lead to rheumatic endocarditis. Now, this is less likely to happen now because are we treating strep throat now? Yes, doctors insist on treating strep throat. Okay, in fact your kids, right? And kids get diagnosed with strep throat automatically given antibiotics. Okay, if you're positive for strep throat, it has to be treated. What's the complication if we don't treat strep throat? This is it. Okay, the patient will develop rheumatic fever and therefore rheumatic endocarditis. Can the patient die? Yes, you can die from endocarditis. Okay, if you survive, you will have lifelong heart problems because rheumatic endocarditis will damage heart valves. And we already know what will happen if you have a damaged heart valve. What will you develop? Heart failure. And then can you develop blood clots as a result? Yes. Okay. So if you don't die from heart failure, you can die from a PE, a stroke, or heart attack. Okay. So do you want to get rheumatic endocarditis? So do you want to treat strep throat? Yes. So strep throat is easy or hard to get? To treat? Easy, just one course of antibiotics, right? 7 or 10 days, that's it. You're done with strep throat, no complications, okay? The problem becomes if it's not diagnosed and therefore not treated, okay? So long ago, so this is the time of the boomers when we didn't really give that much not much of a big deal for strep throat. Okay, so treatment during that time, during World War II, was just whiskey, right? And the boomers had the strep throat, just drown it with whiskey, it'll go away, right? As a result, many of the boomers developed rheumatic fever and therefore had rheumatic endocarditis. Yes. Yes, most common causative organism is strep throat. Group A beta hemolytic streptococcus. So here's a short story on rheumatic fever. How do you get it? Again, it's very preventable. You diagnose and treat strep throat, then you don't get rheumatic fever. So look at these manifestations. All signs and symptoms of what? Strep throat. Any questions on rheumatic endocarditis? Yes. No, rheumatic fever is if the strep throat is not treated. Yeah, you develop rheumatic fever and then rheumatic fever always leads to rheumatic endocarditis. And that is damage, right? It becomes, your valves are damaged here, okay, once you have rheumatic endocarditis. Once your valve is damaged, then we have to either repair or replace it. And then that leads to heart failure. So something simple, preventable, easily treatable led to something chronic, right? Okay, let's go now to infective endocarditis. So what is this? This is by the term itself, infective. It's not necessarily contagious, but this is obviously caused by an infectious organism. So it can be caused by bacteria, viruses, fungal, or fungi, but most commonly it's bacteria is involved. So who are at most risk for this? How did this infection reach your heart? Okay, so is this an infection? So therefore, is there the concept of chain of infection here? All right, so what are the 6 links again in the chain of infection? Well, causative organism first, infectious organism. Next, there's a reservoir, right? Okay, so a reservoir can be a object such as a needle, an infected needle, or it could be a person, correct? What again? How does it leave the reservoir? The portal of exit. Okay, can a reservoir be a living person? Yes. Can either an object such as again a infected needle and or could be a human. So it leaves the reservoir portal of exit, right? And then what's the portal of entry? Same portal of exits are also portals of entry. Now we have mode of transmission, correct? So mode of transmission could be droplet, contact, okay, enteric, airborne, all right? And then we have the infectious host, correct? Okay, so who are the, no, sorry, infectious host, the susceptible host, sorry. So what are they, 6 links again? We have the infectious organism, the reservoir, port of exit, port of entry, mode of transmission, and the susceptible host. Now, it's not just any host. The host has to be susceptible. Okay, so who are the susceptible hosts? Number 1, people who use illicit IV drugs, meaning your IV drug users. Okay, so you're illegal IV drug users. Others are older adults who have prosthetic heart valves or other cardiac devices. Cardiac devices include either ICD or a pacemaker, right? So these are your infectious hosts. Who else? People who require long-term IV therapy, because what will you have if you require long-term IV therapy? Central lines. Okay, so people with central lines. Who are they again? People who IV drug users, older people who especially who have heart valves, okay, prosthetic heart valves, who again, people with central lines. And of course, we'll throw in here anyone who has immunosuppression. Okay, but if we go to city hospitals, so most cases of endocarditis we see are IV drug users. Okay, so majority are IV drug users. I'd say more than half. Right? But of course, don't generalize because you'll see little old ladies that, oh, how did this little old lady? And then you see, are you an IV drug user? No, of course, they have either a heart valve problem or maybe they had central lines. Okay. Other less common portals of entry, because these are portals of entry, yeah? The IV drug use, the central line, these are portals of entry. So other portals of entry are deep wounds. Okay, let's say infected pressure ulcers, for instance. So that could be your portal of entry. Now, how does the causative organism get to the heart valve? Why do they attack the heart valve of all places? Okay, why do they choose to cause endocarditis? Well, it's actually pretty simple. If you are, let's say, a streptococcus or staphylococcus, okay, so let's say, okay, Sophia, let's say you are staphylococcus. What do you need to live, to survive? First of all, do you need a husband if you're a staphylococcus? Is that how you multiply? You have to have sex? A staphylococcus? They mate? Do they have sex organs? No, they multiply asexually. Okay? They don't need a partner. They multiply automatically. So what do they need in order to multiply? And what did God say? Go to the world and multiply. Yeah? Okay. So how do they do that? What do they need to survive? What are the two things every living organism requires? Oxygen and glucose. Tell me where you would find the finest oxygen and glucose in the body. Where? The brain is actually the largest consumer. Your brain eats up 25% of your body's oxygen and glucose. So it's not a source, it's actually a consumer. Try again. So where is the source? Where would you find the best oxygen and the richest glucose in the body? Which part of the heart? The left or the right side? Why aren't you sure? Why is it like question mark? Why the left side? That's correct. The left side has oxygenated blood. Right side, I'm not going there. There's no oxygen there. It's the dirtiest blood. I'll go to the left side. So what will I do once I reach the left side? It's like paradise. Okay, Sophia, the Staphylococcus, when she reaches the left side, oh my God, I'm in heaven. It's the best place ever. I'm never leaving this place. Okay, I'll have my children here, my great-grandchildren, and my great-great-great-great-grandchildren. I'll build houses here. Okay, so they'll stay in the heart valve because that's the only place they can create houses. They cannot build anything on the walls. The walls are smooth, but look at the structure of a heart valve. It's very rough, right? It's very rough. And however, when they stay there, is it a peaceful environment though? When they live in the heart valve? The valve opens and closes 60 to 100 times a minute. Is it a peaceful place? So therefore, the houses that they make, are they going to be indestructible? No. Eventually, these houses they make, when I say houses, these are actually vegetations. So vegetations are like houses, okay, that the bacteria make. And the problem is because this is again not a very peaceful place. So will these houses get destroyed and become emboli? Yes. So bits and pieces of these vegetations become emboli. They're not clots, but they are solid debris. And can they block circulation somewhere? Okay, so let's go now to the pathophysiology. So what happens? So long story short again, the bacteria finds a place. Where is that place again? That's the best source of sugar and oxygen. The heart valves. Which side? Left side or heart? Okay, most commonly affected valve therefore is what? The mitral valve. Of course, they can infect the tricuspid and the pulmonic, but is it commonly affecting those valves? Will they likely infect those valves? Not likely again, because is the right side a good place to live? No. I'd prefer if I were like Sophia, I'd go to the left side. Okay. So here's the long story short. So they make vegetations. Okay, these are clusters. But then again, like I said, vegetations, this is not a peaceful place. These vegetations will break off, become emboli. And now they'll cause problems all over the body. So when they do that, this will appear on the manifestations. Here's your summary of risk factors, chart 24-6. So select all that apply question who are at risk for infective endocarditis. Here are your answers. I forgot to mention another portal of entry would be dirty tattoo equipment. Okay, so if you're fond of inks, make sure you go to a reputable, shop, say what, ink artist or whatever they're called, okay? So make sure they use clean equipment, right? Hemodialysis also, because they sustain repeated sticks, okay? So again, same as IV drug use, yeah? Manifestations. This is an infection. So the patient, will they look sick? Will they feel sick? Yeah, yeah. So how do you feel when you're sick? Yeah, you have a fever, you have body aches, you're not happy, right? Yeah, you're tired, this hurts. You don't feel like doing anything, you have no appetite. So just same thing as any other patients would have as an infection. But because this causes valve damage, what will happen to the patient? What will they develop once there's valve damage? Heart failure. Before it goes to heart failure though, once there's a valve damage, so can the valve either not close or open now? Yes. So what will you hear on examination? A murmur. Okay, so what produces a murmur sound? A valve that is leaking, yeah? Okay, so the leaking valve, meaning blood is going back into one chamber. So that will produce a murmur. So the patient will either have a new murmur, or if they had a murmur before, there will be a change in that murmur. Okay, so this is a new acute problem. So there's a murmur, like I already mentioned, fever. And then remember those emboli, those vegetations that break off and block circulation? Okay, when they end up in your hands and your feet, they will form Osler's nodes, Janeway lesions, or Roth spots. The description are here, the location are also here in this paragraph. These three manifestations are exclusively found in endocarditis, in infective endocarditis. No other condition in textbooks produce these three. So when we see Osler's nodes, Janeway lesions, Roth spots, meaning the doctor sees these, what will be the conclusion? What do they have? Infective endocarditis. Because again, these are almost exclusively seen only in people with infective endocarditis. Other problems would be, although not very common, see only 22 to 50% of the people, they may have a problem with major arteries, meaning this can lead to a heart attack, a stroke, or a pulmonary embolism. Okay, but not very common. So that's between 22 to 50%. I already mentioned, because this causes valve damage, so there will be heart failure. So will this patient be treated for heart failure? Yes, on top of, now for infective endocarditis, since we know once there's heart valve damage, then they have heart failure, so we treat them with as heart failure. However, what do we do with the infective endocarditis itself? What's the nature of the problem? When you have infective endocarditis, what do you have? An infection, correct? How do we treat an infection? IV antibiotics. Okay. It has to be IV antibiotics this time, because this is a major infection. For how long? A long time. Okay, so let's finish our diagnosis first. So how do we know you have endocarditis? What is our expected test that will be done? How do we know you have bacteria there and whether or not you have valve damage? What test can do that? How can we see your heart valves? What do we call a heart ultrasound? An echocardiogram. Okay, so there are two types of echocardiogram, either transthoracic, meaning you'll put the probe over your chest wall, or a better picture even is if we put the probe into your esophagus. Okay, so that's what we call a transesophageal echocardiogram, which is invasive, right? So of course it will provide the best picture, but a transthoracic is just as good. Okay, if the doctor wants a finer picture, okay, they'll do a transesophageal, a TEE, but a TTE will show you a decent picture as well. Not necessary. Okay. And because it's an infection, so we can see what type of organism is doing the infection. So what will be drawn? Blood culture. So we do an echo, A blood culture will confirm the diagnosis. Will the echocardiogram confirm the diagnosis? No. The echocardiogram will just show you whether or not there is valve damage. How do we know there's an infection? The blood culture. Okay. So we grow the blood culture. Whatever organism grows, we'll target it with a specific antibiotic. So how long will be the antibiotics here? 4 to 6 weeks. See that under management. So the blood culture, of course, was the basis of the diagnosis. So therefore, how do we know we've successfully treated it? Blood cultures again. Okay, so if the blood culture goes negative, then was it successfully treated? Okay. Will the murmur go away after successful treatment?
No.
Why not?
If the valve is damaged.
Because the valve was damaged. Okay, so we have to either repair or replace that heart valve. Okay. Will the heart failure go away?
No.
Fortunately, it'll remain. So prevention, of course, we know the risk factors, yeah? So we had the chart, 24 dash whatever. So you target those people, teach them, IV drug users, you can't stop them from using IV drugs, yeah? But can we give them sterile needles? Yeah, that's better. Okay, so here, I can't stop you from using heroin. Here's a sterile needle instead. Okay? Yeah, there are actually needle distributions in the community. Yeah, in shelters, yeah, they distribute sterile needles. It's better actually, it's actually a genius because do you want these people causing problems? Because whose problems are they gonna be? It's gonna be ours, okay? Yeah, it's gonna be our problem. Okay? It's not like, oh, let them die. No, they won't die easy because when you see it, I'm just gonna let them die. No, somebody's gonna bring them to the ER. Who's gonna pay for their care? It's gonna be your taxes, right? So better to keep them out of the hospital in the first place. Yeah, yeah, give them sterile needles. Okay? They have problems. It'll be a while before we solve their problems. Until then, keep them healthy. All right. Okay. Yeah, we just don't leave them. They have problems. Okay, when people have used IV drugs, did they just do that? No, because they want to. There are underlying problems there, right? Whatever that is. Until then, we give them support. Okay. Another portal of entry which I forgot to mention. Let's go back to the chart. One of the portals of entry is actually the mouth. If the patient has any dental, because whenever you've all went to the dental hygienist. So what happens when your hygienist cleans your teeth? Now just they clean your teeth. What happens in your mouth? Bleeding. So therefore, is it easy or hard for bacteria to enter your body through the mouth? Very easy. Flossing, right? Flossing, brushing your teeth. So therefore, if you have any of those problems, you have dental problems, dental abscess, a dental abscess is not minor, okay? So that's a serious condition because our mouth is very red, very vascular. So is it easy or hard for that infection to enter the bloodstream through your mouth? Very easy. So the mouth, that's why here under prevention, good oral hygiene, right? And also once your patient, once you go to the dentist, if you recall, let's say you go to a new dentist, did they not have you fill out a long set of paperwork asking you a bunch of questions about your condition? One of those conditions on the questionnaire is bowel problems and endocarditis. Did you have endocarditis? Okay. Do you have heart valve problems? When your answer is yes to these questions, that means are you at risk for infective endocarditis? And because the mouth is a very good portal of entry, what will the dentist give you before any cleaning or major dental procedure. Antibiotics, prophylactic antibiotics, because they understand, oh, you're high risk for infective endocarditis. So in their training, they already know, oh, you have this risk factor here under prevention, antibiotic prophylaxis. All right? For how long? Just for now or for life? So every time you go to the dentist, you're gonna have to get prophylactic antibiotics. Are we clear? This is forever, okay? Because does your risk factor ever go away? No. Okay, you have the risk factors, it's gonna be there. Okay, so management. So I already mentioned the antibiotics. So antibiotic therapy here is long, 2 to 6 weeks. So therefore, what's our IV access here? Peripheral or central line? It's gonna have to be a central line. What was one of the portals of entry we mentioned earlier? Oh my God, it was a central line. So we're putting the patient at even higher risk here. So as a nurse, what's the most important responsibility here? Meticulous care of that central line. Okay, you remember what we did for the first week?
Yes.
Okay, we did dressing changes, yeah? So it's important that you do proper meticulous central line care, right? So the patient, so since this is 6 weeks long, do we have to keep the patient in the hospital for those 6 weeks? No, Medicare and Medicaid even encourages to send them out. So if the patient can go home, you're gonna give the antibiotics at home. Or if there's someone you can teach and treat, let's say this patient is a professional, hey, like you and me, nurses. No, we have decent families, decent homes. We can teach the patient, okay, either the patient or a caregiver, a family member who can administer an IV antibiotics. We'll teach and train them because insurance is all about saving money, yeah? So we'll do that. If let's say the patient is an IV drug users, are they gonna be sent home? Are you gonna send an IV drug user home with a central line?
No.
Say I'm using heroin. What will the heroin addict say? They have a central line.
That's easy.
Thank you. Okay. Thank you. That's easy. No more needles. I'll just push. All I need is syringes. Okay, I'll have a party. Alright. So no. So those people will have to be either kept in the hospital or sent to a rehab facility. You're gonna have to eat up the cost, okay? Because they're high risk. Can't trust them with a central line. So of course, we won't wait for the end of these 6 weeks. So every week we will draw labs, CRP, inflammatory markers to see is the treatment working. Of course, at the end of the treatment, that's when we draw blood cultures because we can't draw blood cultures every week. Surgery here, I won't repeat because we already discussed valve repair or replacement. Okay, so if needed, patient may have to undergo repair or replacement of the valve if the damage is that bad. If not, then it'll be symptomatic treatment, which is management of heart failure. And because the patient has pain, we treat them for pain, NSAIDs usually, fever, same NSAIDs or Tylenol. And we watch for complications, specifically related to the central line. Okay, and remember, these patients will have central lines. All right, that's all we have time for.